and welcome to Lynchburg Live. I'm your host, Linda Smith. Our October shows will be dedicated to the memory of Cathy Touna. October is Breast Cancer Awareness Month, and over the past 5 years, Lynchburg Live has brought you a variety of shows dealing with breast cancer. The focus of tonight's show will be radiation therapy and how it is used in the treatment of breast cancer. Some of the pictures that we'll be showing tonight are graphic and may not be suitable for children. My guest tonight is radiation oncologist Dr. Angela Brady, who will be discussing radiation oncology, radiation therapy, and breast cancer. Angela, welcome to Lynchburg Live.
Thank you.
As we get started, could you please just tell our audience what a radiation oncologist is?
Sure. So a radiation oncologist, generally what I tell people is that there's 3 kinds of doctors that take care of cancer patients. There's surgeons, and they come in all different forms, anywhere from, breast surgeons, colorectal surgeons, urologists deal with prostate cancer, head and neck surgeons, lots of different surgeons. There are the chemotherapy doctors, also known as medical oncologist or hematologist oncologist for some of them, and then there's radiation oncologists. So surgeons obviously perform surgery. Chemotherapy doctors give chemotherapy, and radiation oncologists are the ones that prescribe the radiation.
Right. And where are you located?
I'm at the Pearson Cancer Center. I think it's that lovely building sitting behind us right now.
It's a beautiful building, and so multi-purpose. How long have you been there?
I've been here for 6 years, ever since the Cancer Center opened. I was here for just a few months when the Cancer Center, when we were transitioning between Virginia Baptist, where breast imaging is now, and the Pearson Cancer Center.
Now, do you work with patients who have all types of cancer, or do you specifically work with breast cancer? What is kind of your specialty, if you have one?
Actually, we work with all types. There are only 3 of us. It's a very small specialty nationally, and it's a small community essentially. But so I work with all kinds of cancer patients. I really enjoy breast cancer patients. But I work with all kinds.
Where does radiation therapy fall within the treatment guidelines for breast cancer?
So it's a little bit tricky, and there are some nuances, but generally speaking, any woman who wants to keep her breast will talk with a radiation oncologist to see if they need radiation afterwards. There are some that may not. And then for women who've had mastectomies, there are also certain guidelines related to the size of tumor, multifocality, lymph node involvement, lymphovascular invasion, some of the little details that we look at.
For those people who really don't understand, how does radiation affect cancer cells?
So radiation the way that radiation works is that it causes breaks in DNA. And normal cells have really good repair mechanisms, and they can repair a lot of the DNA. The cancer cells don't have as good repair mechanisms, and so when they try to replicate, they have errors in their DNA, and it causes them to die. We hope that's the goal, is to kill all of the cancer cells that you can't see that might be still lurking within the breast or the nodal areas.
Now, is there a specific type of breast cancer that you use radiation therapy for, or are all types of breast cancer candidates for radiation therapy?
So the typical types of breast cancer that we talk about ductal carcinoma in situ, we talk about invasive ductal, invasive lobular. LCIS, which is lobular carcinoma in situ, is not real. It's more of a precancerous condition. It's not really cancer. So those are the big ones that we use radiation for, especially after breast conservation. And then there are other cancers that come up in the breast, like lymphomas can come up in the breast, small cell can come up in the breast. There's something called a phylloides tumor, and we use radiation for all of those as well.
And it's effective?
Yeah, radiation reduces the risk of local recurrence. It's
Great.
Not chemotherapy. It's not going to go everywhere the way that chemotherapy does, but it does decrease the chance that a tumor comes back in the breast or in the regional nodal areas.
Now, do some patients have radiation therapy as well as chemotherapy?
Yes, lots of people have them sequentially. So usually what happens is that if someone is a candidate for chemotherapy, depending on their initial presentation, They may or may not have chemotherapy prior to their surgery. They may have chemotherapy after their surgery, and then usually radiation, I say, is the caboose. We're usually the caboose, so we're sort of the end of the final third of that journey for a lot of people. So we usually come at the end. There are situations where we're not at the end. There are very rare situations where we use chemotherapy and radiation together for breast cancer, but for most people, that's not the norm.
I'm sort of jumping ahead a little bit. I was going to
No,
ask
it's
you these
okay.
questions later, but
It's all right.
since we're sort of in this direction, when a person is having reconstruction after a mastectomy, now, can you do radiation therapy at the same time reconstruction is taking place, or how is that done?
So it's very tricky, and I think it's changed a little bit over the past few years with the way that the mastectomies are done as well. There was a time when a lot of times someone would have a mastectomy and the chest wall would be flat.
Right.
And radiating that chest wall is a lot easier, but that makes the reconstruction a little bit
Right.
tricky because there's no extra skin for the surgeons to work with. So if they think that someone's going to have reconstruction, they have two options. And a lot of times this is a good reason to have what we call a multidisciplinary conversation or conference, which we have every Wednesday morning. I was there this morning. And we all talk about it. Some people who want reconstruction should not have an immediate reconstruction because it can complicate the way that we need to do the radiation and maybe lead to more toxicity of treatment. Some people, we can go on and put in an expander, but with the understanding that they may still have to have a tissue reconstruction down the road. Some people can try and implant reconstruction and do that successfully. But radiation definitely complicates the chances of a good reconstruction because we cause damage to the very small blood vessels that help with healing and the elasticity of tissues.
Right. I think the general public knows about these things, but they don't really understand where things fit in the treatment schedule. All right. Now, tell me some of the various forms of radiation treatment, like, for instance, what's external beam?
Right. So we have a couple of pictures. Can we see the linear accelerator, please?
Phil, can you put that picture up?
There's the linear accelerator. Okay, so this is the most common way that radiation treatment is given, with the linear accelerator like this, and actually at this treatment angle. Could we see the picture of the woman on the table of the linear accelerator, please? There you go. So this is a pretty common way that radiation is given. As you can see, there's a woman. She's laying on a table. She has her arm up. She is in a type of what we call a vac-lock bag. She's in a special immobilization device that lets her know each day sort of how she lays down, where her head goes, where her arm goes. And then you can see sort of the cartoon effect of the radiation beam that comes across her body. And if you look at the inset where the CT scan is,
Right.
you can see her breast. You can see that bright white in her breast would not be a tumor. It would be, for example, a cavity, a surgical cavity. And you can see how the radiation skims across her body, gets maybe a tiny bit of lung that's treated right there, but is able to encompass her whole breast. And then the linear accelerator, after it delivers this beam, it would move around her body. It would have another beam that basically sort of mirrors this beam to treat from the other side, and those two beams together give us depth. And that would be a very simple type of radiation treatment. Now it's much more complicated because we use special field and modulating techniques to make the dose very homogeneous, very smooth across the breast. Sorry, I don't want to get into too much of the medical stuff, but.
And the white area, that is the pocket where the tumor has been removed. Is that correct? Okay.
That's correct. And they intentionally leave that pocket there because, and sometimes they actually will move the breast tissue around to fill it in a little bit faster, but most of the time they will intentionally leave that pocket because they don't close a breast the way that they would close a different part of the body because they want to maintain the normal contour. And eventually that fluid will get resorbed. The when that happens, the breast will lose a little bit of its volume, but hopefully it's not a huge asymmetry.
Right, what's the difference between internal radiation and external beam radiation?
Right.
I may be getting us off into an area.
You're fine, you're fine. So there are some techniques that have been around actually for quite a while. They were initially used more to give extra dose, the boost dose of radiation, which is the extra dose just given to the area where the tumor was removed. But over the years, they've experimented using this for treatment instead of doing the external beam treatment. The different techniques fall under an umbrella called accelerated partial breast irradiation. That's APBI for short. And what that is instead of treating the whole breast over, say, 5 weeks or 6 weeks, we treat just part of the breast. And the way that this is done, could we see the mammocyte catheters, please? What?
The little things that look
the
like
thing
arrows.
That looks like arrows. Maybe? Yes, there they go. So these are, it's not just mammocyte, but there's, these are some different catheters. I think the top one's mammocyte, the second one's probably contour, and the third one's probably a Savvy catheter. These can actually be where the bulb end is inserted into the cavity where the tumor was removed. The other ends actually stick out of the skin. Could we see the next picture, please? There you go, where it would actually come out of the skin. And then just the 1 centimeter around that balloon or that device would be treated. And that has shown some promising results. It's not appropriate for everybody. It's for small tumors, it's for older women. Certainly none of the under 50 crowd gets this. No one, well, there's still a little bit of controversy, and the gold standard study hasn't come out yet, but lots of institutions, thousands of women have been treated well with this. We do not do this in town.
So if we have someone
that looks like a good candidate for it, I usually offer them referral out of town for it. Could we see what's next, please, in the images? This is a different type of internal radiation, okay? This is a little bit more graphic, and I think probably the next picture is even more graphic, but don't switch yet. The picture on the left with the little catheters coming outside of the body, and then you see the slit in the breast,
right.
That would be the lumpectomy incision. And then those catheters would actually travel through the breast. They're the size of like coffee straws. And then what we would do is we hook it up to an afterloaded source. So a little piece of iridium wire would go into each of those and deliver radiation internally. Both of these treatment situations or paradigms are treated over the course of about a week, twice per day.
So this is like
instead of 5 or 6 weeks.
An implantable radiation.
Exactly.
Yeah.
It's not a permanent implant. It's
right.
like a temporary implant. Could you show the next picture, please? This is what it looks like more commonly in an actual breast when you've just
right.
had that. And then the plan, that's the actual dosimetry, what we call the dosimetry plan, is shown next to it. And it can actually give a very conformal dose, which we like, conformality. It doesn't address any of the nodal areas. It doesn't address anything that might be a little farther away, but it is considered adequate treatment. And
is this targeted?
It's a targeted form of treatment. Could you go one more picture, please? Oh, let's see. Well, it's not what I thought it was going to be. We'll show. This is just an example of someone who's had external beam treatment. I was hoping that the next picture would be something different, though. But this is an example of. These are examples of women who have had lumpectomies and radiation. The first one was a woman in her 30s, and I think this is 50s, and then we have 60s and 70s. There is some asymmetry. This
right.
woman had a slightly larger tumor, as you can guess from the volume loss of her breast. But generally speaking, the skin comes back to normal color and those kinds of things. So,
in radiation therapy, how is a specific treatment designed for a specific patient?
So everything is done custom for every patient. Basically, when we know someone is going to have treatment, we bring them in and we put them in that immobilization device that you saw before, and we do a CT scan, usually in the treatment, well, always in the treatment position, and then we look at their body contour. We look at the breast contour. We look at where the lungs are. We look at where the heart is. We look at if someone needs some radiation to go specifically to nodal areas. We often will draw those out on the CT scan. So we might take a CT scan that has, 80, 90, 100 plus images, and might draw on every single one of those images to delineate where the dose needs to go and areas that we want to spare. And then we have a physics team, and the physics team, after we've worked on it some, then they work on it. They figure out how to use which kind of energy beams, what special modifying devices we need. They send it back to us. We say yes, no, maybe move this a little bit that way or this a little bit that way, and it's an iterative process until we have a plan that we think is going to achieve both the treatment goals and have the minimal toxicity.
So it's very personalized
Everything
for the individual
is custom
patient.
for every patient, and every patient's different. Some people have their heart sits in a less favorable location than other people, or the bend. They have something called a pectus excavatum, where their sternum is deeper, and so we have to look at can we shape this off the lung better for that person.
Now, one of the first things that you do when you see a patient before you start radiation therapy is to mark the chest area. And not only do you do it with magic markers of different colors, you get permanent dot tattoos.
Yep. And yeah, there was one on the one of those patients. The tattoos are small. We jokingly say you can have a freckle or a fairy footprint or a polka dot. You can take your pick.
Whatever.
They're all just a dot. That's all they are. They're dots. We used to do more. I'm a voice for let's not put as many on there if we can avoid it, and maybe put them down a little lower so they're not visible right at the neckline. And our therapists do a great job. They certainly don't want to put tattoos anywhere where we don't have to have them, but they're very useful. They are very useful. We use it as a starting point for aligning patients every day, and it's very useful also if someone is in the situation where they had a left breast cancer in the year 2000, and now in 2014 they've got a right breast cancer. We've got their center line. We've got their leveling marks. We've got a great starting point for knowing kind of what was done before, and then we can make special, accommodations for them.
I remember coming home after I'd been tattooed and saying, if you've got a magic marker, to my husband, we can connect the dots,
Yeah.
because you have to have a sense of humor when you're going through anything like this. Tell me about the age of the patient. How does that figure into the kind of treatment that you do?
We tend to be more aggressive with patients under 50.
Which makes sense.
Mostly premenopausal.
Right.
They can have more aggressive cancers. And then really, there is a little bit different, there's a little bit different approach sometimes. Certainly if someone's over 70, sometimes over 80, depending on how healthy they are. And there's study data that says that if you are, over 70, and I mean, all these details are a bit much, but if you're over 70, you have a tumor less than 2 centimeters in size, you're estrogen receptor positive, and you're willing to take 5 years of Arimidex, if you check all those little boxes, then you may not need radiation treatment after a lumpectomy. But we also want to know that patients are going to be reliable, and they still get a benefit from radiation. It's just that it's not a huge benefit, and so people deserve to know what the advantages are and disadvantages are, and we'll still talk with them about that if they're interested. So age matters in whether or not we're going to recommend treatment, but the younger you are and the healthier you are, the more likely we are to treat you.
How often are radiation treatments given, and how long are the treatments?
So for most people, in this country, what we do is called conventional fractionation. So conventional treatment, the daily radiation, 15 minutes a day, 5 days a week, Monday through Friday, weekends and holidays off, is usually about 5 to 6.5 weeks. So anywhere from maybe 25 to 33, 34 treatments. That has been the norm for a long time. There is something called Canadian fractionation or hypofractionated breast treatment that has come along. It's been done for a while in other areas, but more and more people, I would say, in the U.S. over the past 5 years have been doing it, and we certainly do it as well. And if you have someone that is, again, over 50 usually, because age, does still impact the way we think about patients, who is a good candidate for breast conserving surgery and adjuvant radiation, they may qualify for having 16 treatments, or maybe 16 to 20 treatments, or 21. It's still something that's evolving in terms of the algorithms. It's something that we have to be a little bit selective in who gets this. And we have to feel comfortable with sometimes it's hard, I'm trying to think of a politically correct way to say it. If someone has a lot of tissue, if someone has a very large breast or a very large body, then they may not be the best candidate for that, because we have a higher dose per day going through those tissues. You get more hot spots, and we're still developing a sense of comfort about that.
Tell me, how do you protect the underlying tissues, underlying organs from getting excessive radiation while you're doing these treatments 33 days, 35 days?
Yeah. So one of it is just by virtue of the way that the treatment's designed. As you saw before, we have the patient's body, and then the beams come tangentially from the edges so that they just skim the ribs and the lung tissue. That's ideal. If we see that someone has more lung tissue, then we will use some of the blocking on the inside of the machine called the MLCs. We might bring some of these little MLC leaves in to block more of the lung tissue, or to block the heart if we see the heart is part of it. And then, of course, we use clinical judgment. If we know that this patient, probably had a tumor up here, then we're going to block more of the heart down here, because we can, and we won't, cause any impact to the actual treatment by doing that.
Every treatment, every medication has side effects.
Absolutely.
What are the side effects associated with this?
The biggest one is skin change. Yeah. Certainly people talk about radiation burns, and it does have an impact like a burn, or we call it radiation dermatitis, where the skin gets red, itchy, irritated. Sometimes we actually have where the skin will blister or break down, usually in the underarm area or under the breast. Do you have a picture of the German woman who's 4 days out from her radiation? She was I thought this was just fascinating. There was a woman from Germany who posted, she had bilateral breast cancer, and this is 4 days after her radiation treatment. She posted all of her pictures online.
Cool for her.
So this gives you, I know, it's like she's embracing her experience. So this was her with the bilateral breast cancer. She'd had breast conserving surgery. And so this is what the radiation burn looks like toward the end. And I know Dr. Hilliard would not like me using that word because, but it's the word, yeah, because that's the word that our patients use sometimes.
That's what.
This is a little bit out from treatment, where everything that was red has turned to tan. Some of it's starting to peel a little bit. And then as she continues to use moisturizer, can we see the next one too, please? Then she comes back, her skin mostly comes back to normal. She still has a little extra color in those areas. You can see she's got a little bit of volume loss, particularly in the upper quadrant area. And then she ultimately, I don't think I have a picture of it, but she ultimately had implants put in, and shows those off.
But for the most part, your skin and your tissue does go back to about what it was.
The density of the tissue will typically be a little bit different, where you will feel that one breast has a little bit of more dense tissue
Right.
than the other breast, and the volume may be a little bit less.
We only have 2 more
Okay.
minutes, so I have to ask you this one question.
Yes.
What life-saving message would you like to give to women in our audience here at Breast Cancer Awareness Month?
You know, as much as I would love to say go get your screening mammograms, that is life-saving.
Yes.
But the most, I think more poignant is to say that if you know you have breast cancer before you ever come to us, don't wait. Don't wait. We see women, you know, women put themselves on the back burner all the time.
Right.
And we have women who are taking care of an elderly parent. They feel a mass in their breast. They wait a year. They wait 2 years. They wait till it's spread
Right.
somewhere else.
I know.
And then there's not as much we can do for them. We could have saved their life if they came when they first felt it.
So early detection is
Early
still
detection,
the thing.
whether it's, you know, your screening mammograms or it's that second that you notice there's a mass, there's
Right.
discharge that shouldn't be there.
Angela, thank you so
Thank
much.
you so
I
much.
appreciate you being my guest and sharing this information with my audience. I hope you've enjoyed tonight's show and have a better understanding of the role radiation therapy plays in treating breast cancer. My next show will feature a survivorship study following a group of women after treatment for breast cancer. Thank you for watching. Have a wonderful evening. Good night.